Okay, welcome back. So let's start with interstitial and infiltrative pulmonary diseases. So these are yet another very important group of disease in the pulmonary tract that can also be restrictive in nature to an extent that we'll be able to see. So with this interstitial or infiltrative pulmonary disease, our major focus is in the lung parenchymal space. How we are able to have some disease processes at this particular place, even though there are some other disease that will see them maybe spreading from the bronchus and even reaching this interstitial space, but majorly the focus is on the interstitial space, or rather the lung parenchyma. So it is very important for us to understand this, because these have a major mimicry with things like pneumonia and even pulmonary TB, because most of the time pneumonia and pulmonary TB will be amongst the major presentation that our patient will be diagnosed with. So in the event that maybe we do not get a pneumonia or a pulmonary tuberculosis, these groups of disease offers a potential differential diagnosis of the same, where if you are able to know alternative diagnosis or even alternative treatments that is away from pulmonary TB and bacterial or some other form of pneumonias, we are able to treat our patient with much accuracy. So they are also very, very important. So when you talk of these diseases, it is rather a group of condition that can again be referred to as diffuse parenchymal lung disease, and they are also significant. As we can see, they account for 15% of the respiratory clinical presentation that we might able to encounter in our course of practice. They are characterized by various degrees of inflammation and fibrosis, initially affecting the interstitium of the lung, as we've been able to say, and typically presenting with extorsional dyspnea with or without cough. So they share a major presenting symptoms with the other disease that we've discussed so far. Frequently considered collectively, as they share sufficient number of clinical and physiological and radiological similarities, that is in terms of presentation. So one of these diseases that we'll be able to see, an example, sarcoidosis. Sometimes we might not be able to single it out as a one disease. We might sometimes just say that this patient is likely to have a diffuse parenchymal lung disease, while in some clinical circumstances it might be necessary for us to single out the specific disease, because we know that there are specific disease that could have a specific cause, and if there is a specific cause, we might need to direct a specific treatment of the same. So when we talk of the diffuse parenchymal lung disease, it is in respect to a number of vast number of conditions, where we have various categories. So various categories from the table we can be able to see, like the most common one are granulomatous kind of diffuse parenchymal lung disease. So where it has various examples, as we will be able to see, sarcoidosis as one of the major. And we can also have yes, a diffuse parenchymal lung disease, but we are not really able to tell us the cause of these particular diseases. So these are some of the diseases that are associated with that. So those of known causes, we can attribute them to autoimmune rheumatic disease, exposure to some asbestos, cilia, beryllium, and radiation, and also some other form of drugs can also give us some pulmonary problems. These include methotrexate, amiodarone, and nitrofurantoin. I think we've interacted with amiodarone and nitrofurantoin. Maybe the methotrexate we might yet to. We can also have another group, idiopathic interstitial pneumonias. So this represent pneumonias maybe where there's some form of inflammation at the interstitial space, and we are not able to attribute this pneumonia to a specific cause. And we can also have some rare causes, though they can occur, but they are very rare. Lymphangiomatosis, Langerhans cell histiocytosis, alveolar peritonitis. So as we can see, we are having a vast number of conditions. So according to our level, maybe we'll need to focus on those particular diseases that maybe proves to be more common in our clinical practice. If you are able to identify, even if maybe not manage it competently, at least we can be able to form the basic or nice framework, maybe for referral or even for initial treatment. So identification of these particular diseases are very, very important. And on top of that, on top of identifying maybe the important, it is also good to notice this, because some of these primary disease that maybe we've been talking of, maybe in the upper respiratory tract and also in the lower respiratory tract so far, they also have the potential of giving us the complication that could also be linked to this diffuse parenchymal lung disease. This specifically referring to maybe things like some form of infections that cannot be that might not be limited to TB. We can also have some pneumonia, bacterial or whichever other form of infectious pneumonia, giving us a potential of getting diffuse parenchymal lung diseases. So and as we proceed from the idiopathic interstitial pneumonias, we are able to see some association with these idiopathic interstitial pneumonias. So we can having the chronic fibrosing type, we can having the acute or subacute fibrosing type, we can having those which are smoking related. So we have various ways of classification, but what we need to remember, we have the 4 major classification as was seen in this particular chart. So how are they likely to present in generally, because we say that they are a collective group of diseases. So they are likely to present with cough that is likely to be very dry, and it's likely to be persistent and depressing. And also because the lung parenchyma is at attack or risk, we are likely to present with some form of breathlessness that is usually again slow, progressive, of insidious onset, acute in some cases, if there is something, some factors that can maybe exacerbate. In clinical examination, that is specifically examination, what can we get? We can get crackles, typically on the bilateral side. Again, finger clubbing or clubbing is also common, especially in the context of fibrosis, pulmonary fibrosis, as seen in the other types of this particular group of disease. In example of asbestosis, you can also get a central cyanosis, and also sign of right heart failure in advanced disease. So these are also some of the diseases that can be associated with copulmonale. And in the chest X-ray, what do you expect? Because of the disease process in the interstitial space, if it happens in if this disease is chronic, it is likely that we might develop some form of fibrosis, and that will lead us to get we are likely to get some relatively small lungs in volume, especially in X-ray, with some also reticulonodular shadowing, but may be normal in earlier or limited disease. This is because there is a possibility of an infectious process, and we might have nodules, or rather lymph nodes, enlarging because of the same. And also with the CT scan, we are also likely to get some combination of ground glass changes, reticulonodular shadowing, honeycomb cyst, traction bronchiectasis, depending on the stage of disease. So most of these features are we are able to be reported to by consultant radiologist. Pulmonary function, again with this kind of disease, they are likely to be restrictive in nature, where now if we have this interstitial infiltrative disease occurring for a very long time, the lungs might develop some form of fibrosis, and that may be hindering their capability of expanding. So therefore it can also be termed as restrictive or constrictive in nature. And as a result of that, that will have a great impact with the findings in the saturation of oxygen, and also if somebody was to do some form of BGA or blood gas analysis. So our number one disease under this context that we are likely to get clinically, and these are likely to prove some major differential, especially in the context of pulmonary TB, we are likely to get sarcoidosis. So this is one of the disease, as we are able to see over in that particular chart. This is one of the granulomatous disorder. So as the word granulomatous might suggest, we are acknowledging that we are having some form of white blood cells encompassing a disease process in a very chronic way. For example, even in the context of TB, where we expect some form of granulomatous. So they so these are marked with that form of presentation. So it commonly affects the young adults, typically present in bilateral hilar lymphadenopathy. Presents with bilateral hilar lymphadenopathy, pulmonary infiltration, skins or eye lesions. So it is a disease that is beyond the respiratory tract, as we've been able to see some multi-system disease. Epidemiologically, this is a common disease of unknown etiology, and it is often diagnosed or detected in the chest X-ray. It is most common in Northern Europe, but uncommon in Japan. It occurs more frequently in Afro-Caribbean patients who are more likely to develop extrapulmonary or chronic disease. So in the context of Northern Europe, again, our race, those together with those of Caribbean descent, are likely to have this particular kind of disease. So this can affect any organ, but has the predilection for the lungs, involvement of up to 90%. So just like in what we were able to see in the CF or in the cystic fibrosis, also this particular disease is a multi-system or multi-organ disease, but the clinical presentation are likely to be attached to the lung. So the presentation may be with the respiratory symptoms, but it is not usual. But it is not unusual for the diagnosis to be made incidentally on the chest X-ray. So this means somebody could just be okay. They are going to do a chest X-ray because of some other issues, and then incidentally we get features that are inconsistent with sarcoidosis. So the common extrathoracic manifestation include the eye, skin, lymph node involvement, and constitutional upset or fatigue. Is frequent and often refractory symptoms. So what are the possible pulmonary manifestation? Although pulmonary involvement may be incidental finding, so cough, exertional breathless, vague chest symptoms are common presentation, and even in symptomatic individuals, the chest is often clear to auscultation, although wheeze may be evident if there is any involvement of the airway with the endobronchial disease. So it is usually interstitial disease, but if it has progressed to involve the bronchus, wheeze can also be a finding, but ordinarily we might not expect it. So the disease, most of the time, it can be diagnosed using some form of an X-ray or some form of imaging, and as a result of that, we have 4 stages in regard to the same disease. So the 4 stages can also pose some prognostic relevance, and also they can also be used to inform how maybe we can manage the particular condition. So stage 1, we have the bilateral hilar lymphadenopathy alone. So 55 to 90% there'll be spontaneous remission. So in stage 2, we could be having now the bilateral hilar lymphadenopathy with pulmonary infiltrates. So initially we have the lymphadenopathy, and we are having now it is spreading to involve the lung parenchyma, or it is infiltrating. So this also has the possibility of resolving in 40 to 70%. And we can also have pulmonary infiltrates without bilateral hilar lymphadenopathy. Remission is between 10 to 20%. And stage 4, we can get the fibrosis. Now the infiltration has gone beyond time, and because of that persistent inflammatory process, we get the fibrosis. So remember, these are the same features that maybe somebody through an X-ray can be able to diagnose maybe things like TB or even pneumonia. So they are very, very important to pose as a differential. So what are the clinical prevalence of the above? So bilateral hilar lymphadenopathy, symptom, of course, it's on both sides. By the time somebody is having this, they are normally asymptomatic. Occasionally it is associated with a dull ache in the chest, malaise and fever, mild fever. So this is giving somebody a clue that somebody at this particular stage is likely to tolerate, or rather have this presentation for a very long duration of time. Because you can just imagine a scenario, maybe your patient have been having just a dull pain that maybe might not be too concerning for them, and that for that reason is just giving this disease time to progress. So what are the differential diagnosis when you get a bilateral hilar lymphadenopathy? This can also mean that somebody could be having a lymphoma, a very dangerous disease, a malignant that involves the lymphatic tissues that can spread by way of lymph nodes too. So it can also mean lymphoma. So at this particular case, aggressive investigation need to be done with speed to rule out the potential harmful lymphoma. It can also mean pulmonary TB. Of course, TB sometimes we tend to have some hilar lymph node lymphadenopathy or enlargement that can be asymmetrical or symmetrical. It can also mean some other form of carcinoma, because we know some form of one of the way with which we can have cancer spreading is through the lymphatic pathway, and this can use the lymph nodes, and in the process our lymph node can enlarge, and this is rarely symmetrical. So that is the bilateral hilar lymphadenopathy. The findings that we can get on X-ray, the clinical symptoms at this particular stage likely to be somebody likely to be asymptomatic, maybe apart from dull chest pain that could be tolerated, and we also there's need for us to identify or appreciate major differentials. So the reason for why it is good for us to understand this, we get an X-ray that we are not comfortable maybe to interpret. We send it to a radiologist. A radiologist might give us some of the findings and say that this is a bilateral hilar lymphadenopathy that maybe, and again maybe propose the possible differentials. So if we find ourselves in that particular space, well, at least we should be able to know what to do at that time. And in the pulmonary infiltration, so this, even if you look at an X-ray, there'll be some form of whitish appearance suggesting some form of infiltrate, like the way an infectious process can spread. So although the lungs field might appear normal on plain chest X-ray, the lung parenchyma is frequently involved, as shown in the CT scanning, and symptoms may be minimal or even absent, despite quite marked radiographic abnormalities. So these are very interesting, because maybe when the symptoms are not severe clinically, somebody is not likely to be sent to do a chest CT scan, or rather things like CT scan, because they could be expensive and they could also prove to consume time. So somebody is likely to miss this out. But in the event where maybe the patient keep on presenting with these symptoms, however mild they are, and you are not able to settle on any diagnosis, you might just send them and do the same. And these are some of the interesting features that we might be able to come up with the pulmonary fibrosis. We are not required to understand this in depth, but this is just giving us the examples in terms of what we can be able to see, the lymphadenopathies, and also we can be able to see in the type in the B, where we are having some form of infiltration. So just these markings over here, but we are not required to know that with greater degree. So we just need to acknowledge that these features are able to be obtained through a CT scan. So by the time we are requesting for the same, we expect some form of reporting from consultant radiologist. Unless maybe they are wrong, we can also use our clinical knowledge to either affirm or disapprove whatever finding they might give to us. So we also have the extra pulmonary manifestation of the same. So where we admitted that this can affect various organs. So we have cutaneous sarcoidosis and ocular sarcoidosis, the most common extrapulmonary manifestation, but also cardiac and CNS are also very important clinically. So this can be easy for us. Somebody presenting with severe respiratory or rather generous respiratory syndromes, and maybe in your general examination you are able to identify some form of skin lesions that we can attach it to some form of sarcoidosis, and also we are able to see some ocular lesion. Somebody can move with much speed, or rather they can raise the suspicion of this patient having a likelihood of pulmonary sarcoidosis. So we have the eye lesion. This is likely to be seen in 5% of the patient, and also skin lesion that is likely to be seen between 10 to 30% of the cases. Some of the findings that we might have come across are things like erythema nodosum. So in the context of erythema nodosum, and we are also getting respiratory syndromes, we should know on what to conclude. We also get some lupus panio, indurated erythromatous, may be seen over faces or even ears. So we're expecting some form of lesion, both in the skin and both in the eyes. So this can give us the general characteristic of what we might expect with the sarcoidosis, more so from within various organs. So for us, for the respiratory, well, there are symptoms that we might expect, but principally we might go with the X-ray, where we get where we expect some bilateral hilar lymphadenopathy, with also some infiltrates and also fibrosis. So if this affects the eyes, what do we expect? There are also some eye conditions that we can get. We are able to see over there anterior uveitis, Sika syndrome. If it affects the brain, we can give some patchy meningitis with some form of also space occupying lesion, and some also other diseases such as the diabetic insipidus. So in terms of clinical symptoms, we can also be able to extrapolate from the others parts that are affected. But the most important thing in the context of respiratory, we can use these other symptoms at least to try to distinguish it from the other condition that might be having a similar presentation. So how do we investigate? Number one, we need to do a chest X-ray. So chest X-ray, it can give us the modality of staging, even though some might not be clear, like the pulmonary infiltrates and fibrosis also to an extent. We might also need to do a high resolution chest CT scan to give us a full analysis of the same. We can also do ordinary full blood count. What do we expect? There might be a mild normochromic, normocytic anemia with raised ESR. At this particular stage, these findings are very non-conclusive, but can also be associated with sarcoidosis. We can also have biochemistry. This is just by acknowledging that Sarcoidosis can also affect various organs. So biochemistry, if the disease has a renal involvement, may require renal biopsy and first-line treatment. We might also get hypercalcemia that occurs in 10 to 20% of those with sarcoidosis. We can also get some hypercalciuria in 30 to 50%. Activated macrophages. Activated macrophages in the lungs and lymph nodes are able to hydroxylate vitamin D directly. That is independent of parathyroid hormone, leading to increased intestinal absorption of dietary calcium. So that is one of the reasons why we might end up getting hypercalcemia in the context of this particular disease. Also, some other tests that might also be important: serum ACE levels. This is elevated over 75% with untreated sarcoidosis, but raised but lower levels are also seen in patients with lymphoma, pulmonary TB, asbestosis, and ciliosis, limiting the diagnostic value of the test. So we can also do the cardiac test, the ECG, echocardiogram, and many other tests, because many organs are being are affected. And also in terms of investigation, maybe we might want to narrow them according to maybe how the patient is presenting. So if we do not maybe expect some cardiac issue, we might limit that, unless there's also some other risk factors that we might also want to tie it along to our patient. At that maybe particular point, the cardiac test could be very important. And also it can also be good to do the lung function test. This is likely to come in the initial stages, where you are likely to term this disease as a restrictive, or we are likely to get restrictive features from the lung function test, and they might give us maybe an impression that this could be a parenchymal infiltration disease, or a disease with some form of fibrosis. So this is just important in trying to rule out, or rather affirm, that this is not an obstructive disease, even though we might also get it might also lead us to some form of obstructive disease, because the infiltrates can spread. Remember, this is it is an inflammatory process with the development of granulomatous, so it can spread from the interstitial space into the bronchial space, and at that particular space, if you do the lung functional test, you might not get a clear picture, or rather a clear distinction between restrictive and obstructive. So if that happens, we should not be overly concerned. We'll be likely to understand why that might happen. So how do we manage? The natural history of sarcoidosis is unpredictable and varies from spontaneous remission to inexorable progression, and that in small number, that is 1 to 5%. And even once remission has been achieved, the relapse rate are particularly high. So systemic treatment is indicated for hypercalcemia. So by the time somebody is having hypercalcemia or an extrathoracic major organ involvement, that is if it's neurological, cardiac, or ocular disease resistant to topical therapy, we might now want to direct a systemic management towards the sarcoidosis. So the treatment of pulmonary sarcoidosis is less clear-cut, as spontaneous resolution is frequently seen, typically within the first 6 months. Moreover, although corticosteroid may improve radiological appearance, this is not consistently reflected in improved lung function tests. So corticosteroid can prove to be one of the systemic drugs that can be used, but even though in so using, it might not largely improve the lung function tests, especially as we do it routinely or maybe under follow-up. So treatment is therefore reserved for patients with troublesome symptoms, deteriorating lung function, or radiological evidence of disease progression. So the first line treatment is with the prednisolone or its equivalent, that's prednisone. You can give it from 0.5 mg per kg for up to 4 to 6 weeks, gradually tapering to a maintenance dose for at least 12 months. So you can give it aggressively for 4 to 6 weeks and maintain this person on a drug for 12 months. So remember, this is sarcoidosis. It is also an inflammatory disease that is of granulomatous in nature. So granulomatous in nature, we are drawing that distinction from the pathological findings that you might find just from an ordinary inflammation, and also from an ordinary inflammation as compared to maybe this granulomatous form of inflammation. So inflammatory drugs are very, very important. One of them, corticosteroid, prednisolone, and also we can use other anti-inflammatory drugs that are as known as also immunosuppressant. This include methotrexate, azathioprine, hydrochloroquine. So this has been used in place or maybe when you've given your prednisolone and maybe no much response. So relapses are common on withdrawal of the therapy. Lung transplantation can also be considered in some patients, especially those with stage 4 or those with respiratory failure. So that is what we expect with this particular kind of disease. So what we need just to remember, so maybe rather than assuming that somebody is having some pulmonary TB, it can be good to single this out as a condition, because if you are able to single sarcoidosis, we are not seeing the role of anti-TB in this particular disease. Instead of maybe somebody being on anti-TBs, alternatively they could be in these immunosuppressant drugs, and they might prove to be helpful. So that is number one. So we also have idiopathic interstitial pneumonias. So we are getting inflammation of the lung parenchyma, where we are not really able to isolate the cause specifically. So the clinical diagnosis, so this just gives us a further classification of the same, where we have the idiopathic pulmonary fibrosis, desquamative interstitial pneumonia. So remember, in the idiopathic pulmonary fibrosis could be differentiated from the pulmonary fibrosis that we expect with the sarcoidosis, because by the time you are getting pulmonary fibrosis associated with sarcoidosis, we ought to have established that pattern from hilar lymphadenopathy, from the infiltrate, and eventually into pulmonary fibrosis. Somebody can be able to associate that with a particular sarcoidosis, but sometimes you get just pulmonary fibrosis and you are not able to isolate the cause. This should also be termed as idiopathic interstitial pneumonias. So there, where we have various types, as we can be able to see in the table. So specifically from that group, we have the idiopathic pulmonary fibrosis. So idiopathic pulmonary fibrosis is the most common of those idiopathic interstitial pneumonias. It is progressive and ultimately fatal disease of unknown cause. So by the time you are just doing an X-ray or this other form of imaging, possibly the CT scan or MRI, you are just able to see some form of fibrosis, and with that form of fibrosis you are not really able to tell exactly where it came from. So the onset is usually in all patients, normally in 60s and rarely in below the age of 50. Males are also at much higher risk of being affected, that is twice. The key features is an heterogeneous appearance with areas of normal lungs punctuated with marked fibrosis, honeycombing mainly in the subpleural space, and fibroblastic foci dense proliferation of fibroblasts and myofibroblasts. So this we can be able to see this on an X-ray, or it can be able to be reported for us from the chest CT scan. So it is thought, even though the cause is not that clear, but it is thought that repetitive injury of the alveolar epithelium caused by currently unidentified environmental stimuli lead to activation of several pathways responsible for the repair of the damaged tissue. Just as we might have known, by the time somebody is getting fibrosis, it could be representing some late form of inflammation, and where if it is a late form of inflammation, we need to appreciate that before we get to that point, or we go to that point, there ought to be some other preceding events that could have happened, where at this particular case there could be many, but they remain unidentified. But yes, they remain identified. So however, with this IPF, the wound healing mechanism become uncontrollable, leading to overproduction of fibroblasts and deposition of increased intracellular matrix. So this, if you differentiate it with the normal fibrosis that can occur in the context of chronic inflammation, this tends to happen, or this tends to occur in a very exaggerated manner. So we could, so somebody might say that there is also maybe some form of intrinsic compromise in the control mechanism that we need to get in the formation of fibrosis, where there ought to be some form of a fair balance. So as a result of that, or as a result of the fibrosis or the deposition of the fibroblast, the structural integrity of the lung is therefore compromised or disrupted. And as a result of that, because of this fibrotic tissue, the elasticity of the lung is likely to be fairly or rather significantly compromised. And remember, if the alveolar space is fibrous, it can also minimize or rather constrict their capability of gaseous exchange, so the gas is not able to pass with adequate ease in fibrosed membrane, so leading to progressive respiratory failure. So the respiratory failure could be due to two reasons. It could be due to loss of elasticity. So that means the lungs might not be able to use its mechanical advantage, and also there's the limitation of the membrane in terms of exchange of gas, and for that reason we'll get pulmonary or we'll get progressive respiratory failure. Even though we understand a lot of diseases are likely to give us the complication of pulmonary fibrosis, but in this particular case, the idiopathic pulmonary fibrosis, it is standing alone disease because we are not able to identify the cause. And then number two, the fibrosis is happening in a very exaggerated manner. So what are some of the clinical symptoms that we might expect with this? Because it's also are very common. Patient typically present with insidious onset of progressive dyspnea that may be accompanied by cough, with or without symptoms. So also the time frame in terms of this complication, in terms of this presentation, really matters a lot. Examination of the chest might show bibasal and inspiratory crackles, and therefore it is not uncommon for patient to be mistakenly treated for heart failure and recurrent chest infection before the diagnosis of IPF is made. So this is just to tell us, when we are treating this common disease, somebody just coming more frequently, especially with the same presentation, we might need to up our game, either by sending for the superior investigation such as the chest CT scan, and also maybe in liaison we can consult with the respiratory clinician or even consultant. So also finger clubbing is seen in 25 to 50% of the cases, so at least we have an advantage clinically. If we see that, we think of fibrosis that can be pulmonary fibrosis, and the other form of fibrosis that we've covered, specifically the cystic. Progressive respiratory failure may be complicated by pulmonary hypertension. By now we know how this can connect. By the time somebody is having a compromise in the respiratory tract, how that can affect the pulmonary pressure by way of maybe reduce oxygen, how the blood is likely to the blood vessel is likely to respond to that by the reduction in terms of caliber, especially in the pulmonary space. There's also a stepwise deterioration that can occur due to pneumothorax, pulmonary embolism, or intercurrent infection, but acute exacerbation with no identifiable causes are recognized and are associated with increased mortality. So we also have an acute form of it, Aman-Rich syndrome. So we can just imagining the fibrosis here is happening with speed within a very short duration of time. Occasionally occurs as has a particular poor prognosis. And we might also need to remember these are some of the problems that we are able to see also with the coronavirus, having that, yes, it is just happening within a short duration of time, and then within a short duration of time, if you do an X-ray in a previously normal person, you are able to see some fibrotic features. So when we develop these fibrotic features in a short duration of time, or even eventually, it makes our respiratory function at stake, and we are at a risk of losing it if there is no aggressive intervention in time. So what investigation are we likely to do? Just the same investigation that we've been doing: the respiratory functioning test, blood test, and also chest x-rays. So what we just need to remember with this kind of diseases, when you're doing the investigation, you are ruling out your differentials. You are also checking whether you are getting the complications or not, and you are also so basically that is what we are doing. So the blood test, we can also have the antinuclear antibodies, or known as the ANA, or rheumatoid factors. So they ought to be done, because sometimes this can represent some inflammatory disease that happens in every part of the body, and the lungs might not be spared, and in the context we might end up getting a fibrosis as a result of the rheumatoid disease in general. So those are some of the things that we need to rule out. And also chest x-ray, it is likely to show a small lung volume with increased reticular shadow. Remember the small volume because it is fibrotic, and its expandability, or rather its compliance, has reduced greatly. That is what we should be able to appreciate in the x-ray. And on top of the small, we can also be able to see some form of fibrosis. We can also do the high resolution chest scan, where these are the following findings that we are able to see. Basal distribution abnormalities are normal, pronounced at the base. We can also get some subpleural reticulation, most evident in the lung peripheries. We can also get the tracheal traction bronchiectasis, where we are having the fibrotic processes that distort the normal lung architectures, pulling the airway open and causing bronchiectasis. So because of that pulling force, it might also tend to collapse it in one way or another. This, and also honeycombing. So these are just representation of fibrosis in the CT scan. So this is a chest CT demonstrating idiopathic pulmonary fibrosis. So there is pleural reticulation and honeycombing at both lungs bases. So another form of investigation that might be done, we have the bronchoalveolar lavage. Is necessarily only if an infective or malignancy cause is suspected. Histological confirmation is necessary in some patients. So the differential diagnosis. So the main differential diagnosis is an alternative of another interstitial pulmonary fibrosis. or another interstitial lung disease. Other differential of the chest X-ray appearance include interstitially pulmonary edema, infection, and lymphangitis carcinomatosis. So the prognosis. So the survival this of IPF is 2 to 5 years. So the prognosis is not as good. Serial lung function test is used to monitor disease progression, and 10% decline in the forced vital capacity, and we get 15% decline in the gas transfer, so total lung capacity can reduce. So we need to be doing this lung functioning test at least when the patient comes to our clinic, and try as much as possible to compare with their previous, so we'll be in a position to tell whether they are improving or whether they are deteriorating. So this period of stability may be interspaced with spells of more accelerated decline, but failure to recover back to baseline follow this episode is common. Mortality is increased following acute exacerbation. Immunosuppression is generally avoided in IPF, and steroids are no longer recommended in confirmed diseases. So we are also seeing another importance of confirming, because if we've not confirmed and we are assuming this is an OCPD, we might expose this particular group of patients to maybe corticosteroids or even steroids such as the prednisolone over a long duration of time, and what we'll be doing is to suppressing the immunity, and maybe at this particular state they are already compromised. So if we give them that, we might not be offering any advantage to them. So these are the kind of drugs that are likely to be given. Pirfenidone, an antifibrotic agent, has been shown to slow the rate of the forced vital capacity decline. So this is an antifibrotic agent. I know we've not covered that in pharmacology. We have other treatments that include nintedanib, an intracellular inhibitor of tyrosine kinase. Gastroesophageal reflux disease should be treated if symptomatic, so it is also likely to be associated with the same. Even with the treatment, IPF is life-limiting disease, and transplant assessment should be undertaken in accordance with the local guidelines. So all patients should have the need for supportive care evaluated with oxygen therapy, pulmonary rehabilitation, and palliative care unit. So they might require oxygen therapy for a very long duration of time. So we also have other group like the hypersensitivity and pneumonitis as part of the infiltrative disease. So what is hypersensitivity pneumonitis? So this is caused by an allergic reaction affecting small airway and alveoli in response to inhaled antigen or occasionally following injection of a causative drug. So it is also likely to follow some allergic pattern. So histological features include chronic inflammatory infiltrates and poorly defined interstitial granulomas, together with interstitial fibrosis and honeycomb changes. The allergic response to the inhaled antigen involves both cellular immunity and deposition of immune complexes, causing foci of inflammation through activation of complement via the classical pathway. So when somebody thinks of this hypersensitivity pneumonitis, just like what we were able to cover maybe in the bronchoasthma, so we might think of this as an allergic process that is extended to the interstitial space of the lung. While in the bronchoasthma, we are having an allergic process that is happening mostly at the bronchus. So with the hypersensitivity pneumonitis, we are having some inflammation that is likely to be due to some form of an antigen. but the only difference is that this tends to occur at the interstitial space, hence the name pneumonitis. So what are the clinical features? So can be categorized according to the time course of symptoms as determined by duration and intensity of the exposure. Symptoms include weight loss, malaise and dyspnea, and cough. Auscultation reveals inspiratory quicks due to bronchiolitis and bilateral fine crackles. In this case, wheeze is uncommon, but that does not mean it cannot occur. So we can have it can have an acute, subacute or chronic picture. So what are the difference? So in the acute, the onset is around 4 to 6 hours after the exposure. Fever is common and patient may be mistakenly diagnosed for chest infection. Resolution occurs within 24 to 48 hours following the removal of an inciting agent. So we need to note this as a major differential of pneumonia. Subacute usually occurs with intermittent or lower level exposure. Improvement is seen in weeks to months following the removal of exposure. So chronic, usually no history preceding acute symptoms, tends to just to has slow onset of respiratory and constitutional symptoms. Finger clubbing might be present, and it may progress to irreversible fibrosis. And in that context, the mortality can also increase. So having that this is an inflammation or pneumonitis also has the capability of giving us some form of pulmonary fibrosis, especially if it progresses. So how are we likely to identify this? So it means there's some form of investigation that we can do. So a diagnosis can be made by maintaining a high index of suspicion. So this is by taking a detailed exposure history. So somebody presenting with those symptoms that maybe could be mimicking pneumonia, and maybe they are affirming that this is not the first time it's happening and normally happens in the context of exposure to agent ABC. So there also need to be an identification of the culprit agent or the culprit antigen, the antigen that causes the patient to have this particular presentation. So in the context of typical clinical radiological findings often makes lung biopsy unnecessary, even though we know if you do a lung biopsy, there is some distinctive feature that you will be able to get in this hypersensitivity or in allergic pneumonitis, even though it might not be necessary. So an X-ray might be done, and in that space we might be able to see a normal chest X-ray, especially in acute or in subacute. We are only likely to see some form of changes like in the diffuse small nodules and increased reticular shadowing, maybe in the context of chronic presentation with this hypersensitivity pneumonitis. Also other superior form of imaging that might be required, CT scan again, and also we might want to do the lung function test, even though they are not diagnostic. A restrictive ventilatory defect with decreased carbon monoxide transfer is seen in the chronic disease. So bronchoalveolar lavage might also be done, and it is likely to show lymphocytosis with these inflammatory cells that comes in the context of allergic or some form of chronic reaction. Lung biopsy might also be very important, but we've seen it's not normally necessary. Demonstrate a lymphocyte-rich infiltrates with varying degree of fibrosis depending on the chronicity of the disease. Of course, if it's chronic, we are expecting some form of fibrosis. So also this being allergic, how are we likely to treat this? The key successful treatment is avoidance of the exposure, just as what can happen to most of these allergic processes disease. If you are able to avoid them, the better for our patient. So prednisolone can be used as a corticosteroid, because it will be able to ease the inflammation, and it is normally initiated in the context in patient whose symptoms persist despite withdrawal and from the causative agent. So first treatment, you need to withdraw the causative agent. If it persists beyond the withdrawal, we should be able to now start on the prednisolone. We establish fibrosis by the time this disease have developed into fibrosis. On the type of fibrosis we are talking of, it's the irreversible one. It is likely that it will not resolve. In some patients, the disease may progress inexorably to respiratory failure. That is even despite treatment or even despite intensive therapy. So this is also another group of the pulmonary infiltrative interstitial lung disease. So we can also have some interstitial lung disease, not because we are having their causes principally attached or rather tied to the pulmonary tract, but as a result of a systemic inflammatory disease that could be undergoing in other areas of the body. So one example of such include the respiratory distress syndrome. I know we might have covered this in some spaces, or rather maybe in the pediatrics. It is also one of the most commonest, and also it could also prove to be important, especially in the emergency context. So what happens in this? Acute respiratory distress syndrome is a diffuse neutrophilic alveolitis caused by a range condition and characterized by bilateral radiographical infiltrates and hypoxemia. So we are having inflammation at our alveoli, and now when we're having the inflammation at the alveoli, we'll be able to know maybe the exact particular cells that are affected, and when they're affected, what happens maybe to the level of surfactant. So when we have activated neutrophils that infiltrate the area, they are secreted into the lungs, and capillary permeability is increased with damage of cells within the alveoli. The triggers are infective and an infective inflammatory process. So at least for this, we know a clue on how they might develop from. So we're having both infective and non-infective processes, provided they are inflammatory in nature. These processes results in exudation and accumulation of protein-rich cellular fluids within the alveoli. So our alveoli are filled with some form of exudate, and the formation of a characteristic hyaline membranes. So local release of cytokines and chemokines by activated macrophage and neutrophils results in progressive recruitment of inflammatory cells. So the inflammatory picture that we are seeing in this particular place tend to be progressive. The cause can either be infective or non-infective inflammatory causes. So what happens when we are having the accumulation of that fluid? The breathing most definitely will be affected, and also as a result of the same, as a result of alveolitis, there are some alveoli that will be affected, and this will give a secondary effect that include loss of surfactant and impaired surfactant production. So the net effect of alveoli collapse and reduced compliance, a most marked dependent region of the lungs. The affected airspace become fluid and can no longer contribute to ventilation, resulting to hypoxemia and hypercapnia. Because of the accumulation of that fluid, these are the two consequences that we will be expecting with the same. So how do we diagnose and manage ARDS, or acute respiratory distress syndrome? It can be difficult to distinguish from fluid overload or cardiac failure. So because with this kind of disease, we also expect accumulation of fluid within our alveoli space. So independent of cardiac or other causes of fluid overload, we can also have the acute respiratory distress syndrome. So classic chest X-ray and CT scan appearance are in existence that can be that could be attached to the same. So these are features of the chest X-ray and CT scan for the acute respiratory syndrome. So I said with the imaging provided, we are able to just appreciate some of the general things. Most of them will be liaising with the radiologist, and when we liaise with them, at least we'll not be missing out on most of these conditions that we are likely to diagnose. So the management of ARDS seems to be supportive and including use of lung protective mechanical advantage, inducing a negative fluid balance and treating the underlying cause. Establishing the severity of the ARDS is useful, as a severe disease will require more proactive management, such as prone positioning or extracorporeal membrane oxygenation. So maybe before we proceed, I might just want to remind us that most of this disease tend to also be some complication of this obvious respiratory tract disease that maybe we'll cover, or some that we might have covered, because when you're talking of this RDS, we are acknowledging inflammatory disease that are infectious and non-infectious in nature. Also has the potential of giving us the ARDS. So other example of the systemic disease that we might get and might have also some respiratory compromise are the obvious that we will be able to we might have come across. So one of them, or the most common, is this rheumatoid arthritis and systemic lupus erythematosus. So these are conditions where we are having some progressive form of inflammation that are affecting the connective tissues in the body. Having that, also the lungs also have the connective tissue, that is their interstitial space, and also the alveoli walls, and every most connective tissue that are there can also be affected in the same particular manner. So maybe we'll just do the most common. We do the rheumatoid arthritis. We can just do the rheumatoid arthritis, and maybe at your own free time you can look at the systemic lupus disease as also, or systemic lupus erythematosus, that also proves to be more common. So whenever somebody is getting rheumatoid arthritis, as much as the arthritis is confined to the joints, we should also be able to know that in as much as the inflammatory process is ongoing at the joints, it can also have its implication directly as a form of inflammation to the interstitial lung space. And these are some of the presentation that we might be able to expect under this particular disease. So some could be because of the disease inflammatory process in itself. Some might also be able to come as a result of the side effects of the drugs that are normally used in the context of arthritis. So when you talk of rheumatoid arthritis, it's by appreciating that the same inflammatory process can happen in the lungs, and also the types of drugs that are used could also have some detrimental side effects, or rather effects, harmful effects to the lungs. So in the context of rheumatoid arthritis, we can get the pleural effusion, are often unilateral and tend to be chronic. Low glucose content is typical but not specific. Pulmonary fibrosis occurring in rheumatoid arthritis has a similar clinical features to the idiopathic form of disease, but often allows more chronic course in patient taking methotrexate. It is often impossible to determine whether the fibrosis that patient is experiencing at that point, whether it's due to the underlying disease or due to the drug that they are taking. So either way, methotrexate should be substituted for alternative agents. So if somebody is having a rheumatoid arthritis, they are on methotrexate and they are having some pulmonary fibrosis, it is just better for us to switch it to another agent, just by acknowledging that methotrexate has the possibility or has the potential effect of giving us the pulmonary fibrosis. So we can also get the rheumatoid nodules appearing on chest X-ray may be single or even multiple, ranging in size from few millimeters to few centimeters. These nodules frequently cavitate, and they usually produce no symptoms, but they can give rise to pneumothorax or even pleural effusion. So by the very fact that they could cavitate, this gives us a very potential differential of even things like to do with the cavity that we are able to see in the context of pulmonary TB. So and also in the respiratory tract, when you're talking of the respiratory tract, it is also in acknowledgement that we also have some joints in that space, specifically the cricoarterionoid joint, that can also be involved in the quest of or in the process of getting, or rather developing, the rheumatoid arthritis. So when this particular point is affected, somebody can get dyspnea, stridor, and hoarseness, and occasionally severe obstruction necessitate tracheostomy. So we also have a Kaplan syndrome. So this is due to occupational dust inhalation in those who are having rheumatoid arthritis. It occurs particularly in coal workers and pneumocystis, but can also be caused by exposure to other dust such as cilia and asbestos. So like we had preempted, also drugs that are used in the management of rheumatoid arthritis can also give us the pulmonary features, such as the pulmonary fibrosis with the methotrexate. So this is just a presentation of some of the features that we can get with the rheumatoid arthritis from the nodules that can later develop into cavity with the rheumatoid pneumocystis, Kaplan syndrome in those who are working in coal plant or in coal industry, and they are having rheumatoid arthritis at the same time. And because of the respiratory tract, we can see it having some small airway disease, and we can also have the obliterative bronchitis and also some other presentation. So also an example of interstitial lung disease, we can have the pulmonary infiltration with eosinophilia. So this is a group of allergy respiratory condition, often associated, often directed against helminths or drugs. So most of the helminths that we are maybe some of us or all of us we are able to cover in parasitology. So we were also able to see that these helminths also had a lung phase where they were able to cause some form of lung disease. So this can be categorized as pulmonary infiltratory with eosinophilia kind of disease. So where we have primary eosinophilia can be in the context of antibiotics such as penicillin, tetracycline, or sulfonamides, or NSAIDs, or some cytotoxic agent as used in cancer. So they range from simple pulmonary eosinophilia to fatal eosinophilic syndrome. So these are some of the diagnoses that can be just differentiated by way of X-ray or by way of doing some form of let's say a biopsy. So we are able to see some of the allergens, or rather some of the parasites that are likely to be caused with this pulmonary eosinophilia, or some infiltration marked with pulmonary eosinophilia, where we have the Ascaris lumbricoides, Ancylostoma trucurus, Tricella, tinea, and strongyloids. So drugs such as aspirin, penicillin, nitrofurantoin, sulfonamide has also been implicated. So by the time somebody suggesting this diagnosis, at the back of our mind we are having the possibility of some helminthic infestation, and also we should be able to single out from history if somebody has used these particular drugs. However, even despite us having this eosinophilic picture, most of the time we are not able to identify an allergen. So eosinophilia, we can attribute them to either these drugs or this. So the disease is normally self-limiting, and no treatment is normally required apart from withdrawing the identifiable cause. So we'll withdraw these particular drugs, and we might also deal with this infestation by administering the right antiparasitic agent. So in the more chronic form, all unnecessary treatment should be withdrawn, and corticosteroid is indicated with the resolution of the disease over ensuing weeks. So we give corticosteroids, one of them prednisolone. So you can get asthmatic bronchopulmonary eosinophilia. So the eosinophilia away from the interstitial tissue can also affect the bronchial space, and if it affects the bronchial space because of the constriction, you get asthmatic bronchopulmonary. You can also get the tropical pulmonary eosinophilia, which is termed is the term reserved for an allergic reaction that could be associated to some form of microphilia, such as Wuchereria bancrofti. So we also have some hypereosinophilic syndrome, characterized by eosinophilic infiltration in various organs, sometimes in the arteries. So we have eosinophilic arteritis. The heart can also be involved, where we are having some eosinophilic features. So when we're talking of hypereosinophilic syndrome, it is just in appreciation that we can get the eosinophilic features even beyond the lungs. So we can also have the diseases caused by Aspergillus fumigatus. So this can also be attributed to the pulmonary infiltration with the eosinophilia. So Aspergillus fumigatus can give us what we know as the aspergillosis. So it is also a fairly common disease. So it might also present with some asthmatic features. So these are some of the things that we might want to single out, especially in the context of some form of allergic attack. So there are some people who are specifically allergic to these Aspergillus fumigatus. So this is because this kind of fungi has spores that are readily inhaled and they are there in the atmosphere throughout the year. Aspergillus can be grown from sputum in 15% of patients with chronic lung disease, in whom it does not produce active fungal disease. So they are a cause of extrinsic asthma in atopic individuals. So this poses a great differential diagnosis for chronic asthma, the allergic aspergillosis. So the coercive agent for this is the Aspergillus fumigatum. So we are able to see it also have a various kind of presentation, where initially it might take an asthmatic features, but later as the disease progresses, it also has the potential of giving us some form of complication because of the repeated inflammation that is not limited to bronchiectasis that we are able to see over here. And even with the time, as a result of that complete occlusion, or with the inflammatory process, we might get some form of fibrotic changes that can lead to some form of collapse. So it is also a very, very important disease. So maybe you can go straight to we'll be able to come across this much later in occupational disease. So maybe in the next segment, that is maybe possibly next week, as we'll be winding up with the RS. So where we'll direct a specific treatment. So now what we need to know that With the aspergillosis, we are likely to have the allergic bronchopulmonary aspergillosis or the asthmatic pulmonary eosinophilia that mimics the general picture of asthmatic disease or bronchoasthma, or even an asthmatic attack. So we have last classification of these particular diseases. We have also some other interstitial lung diseases. So these are the rare ones. So maybe if you find time, you can also go through this. The Langerhans histiocytosis that ranges up to diffuse alveoli hemorrhage. So in gross view, this marks this is what we should be able to at least know in the interstitial and infiltrative analysis. We've said